Right. Hello, my name is Jose Sandoval-Sus. I'm an assistant member at the Department of Malignant Hematology and Cellular Therapy at Moffitt Cancer Center at Memorial Healthcare System, and specifically at Memorial Cancer Institute. I'm a active member of FLASCO, Florida Society of Clinical Oncology. And at this moment in time, I am a vice chair of a newly started committee by our president, Dr. Raez, that is called the Disparities Committee. And I serve as the vice chair of that in that committee per se. So we have a very special guest this morning, our president, Dr. Luis Raez, and it's my sincere pleasure to host this interview with him. He's a physician that is is the president of our society, FLASCO, and he's the medical director of Memorial Cancer Institute down here in Broward County. He is also the oncology research director of Memorial Healthcare System and the director of the thoracic oncology program here at Memorial. Uh, he's also you have a multiple different titles, but he's also a clinical associate professor of medicine at the Florida International University and a visiting professor of medicine at Cayetano Heredia University at Peru, his alma mater. Currently, Dr. Raez designs phase 1 to all the way to phase 3 clinical trials in new chemotherapeutic and immuno-oncologic agents in lung cancer and other thoracic malignancies. He also does translational research in areas of cancer vaccines and has been previously funded by the NCI and other institutions. He's very experienced lecturer both in national and international conferences. And he is also board certified in internal medicine, oncology, and even geriatric medicine, which is, I didn't know that. Dr. Raez, thank you very much for joining us today this morning. Really, it's a pleasure to have you. And we're going to focus on one of your pet peeves, on one of your passions that I know that for real, that is the research in cancer, in healthcare disparities in cancer in minority populations. So thank you for joining us, Dr. Raez.
Good morning. Thank you very much for this interview. It's a pleasure to share with all of you this important topic.
So, Dr. Raez, tell us a little bit about yourself in terms of why were you interested on focusing on part of your research, because your research is extensive, but part of your research in healthcare disparities in cancer, specifically minority populations?
Because I think it's very important. In United States, we have a large population of we call minorities. Now we start with Black people, Hispanic people, Asian populations, and probably we're a little bit close to 50% of all of us. And most of the clinical trials, or all of the clinical trials that are national or international, only accrue non-Hispanic white population. So that is, for example, in lung cancer, all the key studies that got the approval of all of these amazing drugs, the checkpoint inhibitors, immunotherapy, the populations are only non-Hispanic white. So the way that this works is that they approve for all of these groups are non-Hispanic white, and then they extrapolate that these benefits of the immunotherapy and the side effect profile will be the same for Hispanics, will be the same for Blacks or African Americans, will be the same for Asian populations, and we know that that's not exactly true. So that is why that's why I'm interested to be involved in disparities and research, because, for example, here in South Florida, in our cancer center, 20-25% of our patients are Hispanics. So we have the opportunity to do research and in diversity, and a lot of our publications in liquid biopsies, immunotherapy, molecular therapies are for Hispanic population. And even if we get the same results and the other publications in non-Hispanic white population, I think it's important to show what are the differences and what are the compared with this other population. No?
Excellent. Thank you very much. And for example, Luis, give us in your field of expertise, that is thoracic oncology. Can you give us an example or something that you have found in your research that specifically is more it that you can see more in minority patients with a specific type of cancer that maybe is changing your approach to the therapy of that population, or that you potentially see in the future changing or personalizing the therapy for a particular type of population?
I think, for example, in the case of Hispanics, it's very interesting because a lot of people years ago didn't put too much attention of research in disparities because they said, oh, they are poor. Because they are poor, they have worse outcomes. So there is nothing else to find. And they thought that maybe doing research in disparities, like some type of research for social healthcare people, like social workers and things like that. But that's not really true. We have discovered that despite of the social concerns or social problems that we have that can explain some disparities, they are also biological disparities. They are a lot of different types of disparities. And in my specific case, for example, in the United States, we discovered that Hispanics have a better outcome, for example, than African American population. And that was interesting because, as I said again, if you do the simplistic approach, oh, everybody's poor, they have worse outcomes. The Hispanics are poor, or they have less access to care. A lot of them are illegal. They don't even. That's what limits the access to care, and they have this all of these impairments to get good healthcare as our African American population. And despite of that, they have better outcomes. So that was very, very interesting to find. And that is why, for example, we do research to find what other factors are involved, and now we know, for example, that Hispanic patients have a higher rate of EGFR mutations in lung cancer that confers them a better prognosis. That's why maybe they have better survivals, because they carry these mutations for what we have oral agents, and not all of our African American population have that rate. Practically, Hispanics have a double rate of EGFR alterations compared with African American or with a white population. So that is why, for example, in the specific case of Hispanic patients, we really have to work hard to find that molecular aberration, because we know that it's a high chance to be there, and not finding that molecular aberration can mean a decrease in the time of life of the patient. So that's why if you have a Hispanic patient that is non-smoker, especially if it's a female, we really need to work one or twice the molecular analysis, because they should have a genetic aberration, for example, and we don't want to deprive the patient of the benefit to have target therapy instead of put them on conventional chemotherapy or immunotherapy treatment. That would be okay too, but the target therapy will prolong markedly her survival.
Well, that's very fascinating, and I can tell you, well, the field of my expertise, we can see all other biologic differences in, for example, in African Americans, and in terms of multiple myeloma. You can see, for example, Hispanics a higher rate of acute lymphoblastic leukemias, so forth and so on, and that can be explained with not specifically socioeconomic issues or social determinants of health, but also about biological differences under diseases, which is one of the reasons that I think is important.
The biological part, I think nowadays is clear. No, I think all of us are now educated that we know that, for example, African American population has a worse outcome in breast cancer, prostate cancer, biological, because there are factors there that put them on disadvantage. But maybe also, for example, the importance that the work that you do in disparities in FLASCO is made them aware about there are other things that are important. For example, education. In the United States, for example, the amount of medical oncologists that are Hispanic or African American are 1/3 of the percentage of the population. So, for example, if African American population is 15 to 20%, only 5% of the doctors are African American. So there is a huge disparity in education for Hispanic doctors and African American doctors, because we don't have the same rate as the amount of people compared with the general population. You can say, but what is the disadvantage of that? No, there are many disadvantages. For example, when we do research, there is a tremendous disparity. You know, African American populations and Hispanic populations don't participate on research. And that is very important, because if they don't participate in research, they don't have the benefit of these new drugs that are already in our cancer centers 1 or 2 or 3 years before the approval. And that can mean saving the life or prolonging the life markedly. And the problem is that a lot of the clinical trials are done in very big fancy centers, not in the community, where we have more minorities. That is why, for example, now one of our national concerns is to push and ask the pharmaceutical industry to open trials in areas where we have minorities. So we not only can accrue minorities, but we can also benefit African American population, Hispanic population, Native population, and they can have the benefit also. And I'm very happy because I have met with several companies, and I see now that for them it's not like they have a quota, but they understand now that not all the trials have to be open in very big places that where the patient has to fly to have access to the drug. Well, then you see the disparity. You know, to be able to have access to the new drug, you need to be able to buy a ticket and stay in MD Anderson 1 or 2 months. So you have to have a lot of economic power to do that, and that is not what happened with the majority of our population. So that is why there is other areas of disparities that we need to learn, be more familiar, and put more solutions.
Oh, I absolutely, and that's fundamental. It's not only is the part of race and ethnicity and so forth, but things that we don't think about sometimes, like rurality. For example, people who live in rural areas have less access to these type of specialized centers, right? Less access to clinical trials and so forth, and that's what the community oncologists they're extremely important to engage with this population, because more than 80% of the cancer care in the US is driven by our colleagues in the community. So all those things are extremely important. I'm glad that you brought it up. This is excellent for us, a segue for another topic that is of our interest in FLASCO, that is the diversity in our institutions, focusing more on our cancer centers and our training programs in oncology and hematology training programs. So, Dr. Raez, what do you think education institutions, academic institutions, and cancer centers or other hospitals can do to try to diversify their personnel? You know, because a diverse institution is an successful institution, from my point of view. So, what are your thoughts on that?
I think, as I said before, it starts with education. As long as our, for example, our oncology fellows are underrepresented, you know, all of these minority groups are underrepresented in the training and education, we are not going to have enough fellows. And that's a disadvantage. For example, for clinical trials, it's much easier if a Hispanic doctor consents in Spanish a Hispanic patient than a white doctor explains in English with a translator a trial to the Hispanic patient. And the disadvantage is not like the white doctor is doing anything wrong. It actually is the Hispanic is the problem, because the patients, for example, culturally, they don't trust clinical trials. Hispanic, for some reasons, Hispanics and, for example, African Americans coming from Haiti don't trust clinical trials. They don't want to participate. So when we are a Hispanic doctor talking in their own language, or Haitian doctor talking in their own language, we make things a little bit easier. And it's a roadblock. It's not an easy task, because the patient at the end, even with his explanation in Spanish about the trial, can tell me no, because I was unable to convince him about that. I think, I don't know, maybe white patients are more educated, and then you don't even need sometimes to present the trial before the white patient already is asking you, because he has read in the news, he knows that you have a new drug in the cancer center that can benefit them. That is why it's important to have minority doctors, minority oncologists in higher numbers, and that's a big problem, as I said before, because we are underrepresented. The American Society of Clinical Oncology, or parent organization, for example, spends a lot of time where at least we have 2 committees covering this area, giving training, grants, access to major meetings, trying to, we even have grants for people that are not, that are doctors that are having oncology yet, so they can start to be exposed to oncology. But that's a major area of concern, because I think it's going to facilitate the training of oncologists if we improve this disparity. From the patient side, also it's important. You know, we need to educate the population, especially Hispanic population, that this can make a difference in their survival. We can improve their survival if they are more sympathetic to participate in clinical trials. And I think it's a matter of education, because I go a lot to Latin America, and the colleagues that live there have a lot of issues with enrolling people also in clinical trials, because a lot of misunderstanding.
Excellent. I totally agree with all those thoughts. And recently, with the under your leadership, FLASCO has started this health disparities committee that I'm vice chair right now, and Dr. Karifu is our chairwoman. And I'm pleased to say that we have started a travel grant for trainees on all different areas of cancer who want to engage or who are already doing research focused on healthcare disparities in the cancer population. So that's a small grain of sand that the FLASCO is doing to try to contribute into the improvement of this area. But I wanted to ask you, as our president, how do you think FLASCO can contribute to improve the healthcare disparities in our cancer patients here in Florida and maybe also in the US?
No, I think FLASCO is doing a lot, because the committee is getting a lot of esteem, and you guys are doing a great job. But for example, FLASCO does advocacy events in Spanish, where we can educate the patients. And in these advocacy events, sometimes in Spanish, we explain the importance of new drugs, clinical trials, access. We tell the patient where in which part of the state they can have access to this. So I think doing these programs in their native language, especially in South Florida, that we have a lot of Hispanic population, has been very, very helpful. And also the other thing that we haven't had much time to talk, we'll talk another day, is about quality. The quality is very different in major cities with more white population than in cities where we have native population, African American population. Because of course, to have access to quality, the cancer center has to invest money. And ASCO has been working with QOPI and soon with another program called Oncology Homes to address these quality issues. Because as you said, 80% of the cancer care is being done in the community. So ASCO is trying to elevate all of these quality indices in the community without the need to invest millions of dollars. Then the population in the community can have a better quality care and elevate the therapy and the cancer care. So that's why we FLASCO work very hard in quality. We even have our own committee. We do the business of oncology meeting once a year. So we do a lot of activities that educate the whole state regarding the importance to elevate quality to the first level, tier 1, because that's the type of cancer care that we want to provide here in our state to everybody. Only one tier of cancer care for all.
Excellent. Thank you, Dr. Raez. That was excellent. So just some closing remarks. Like burnout is very common nowadays, and of all of our cancer, workers, trainees, etc., especially in this COVID-19 pandemic time. So tell us a little bit about, in terms of some personal recommendations, probably to keep your mind more relaxed, or what do you do in your free time? Any recommendations that we can have to maybe to avoid all this burnout epidemic that we're having among our healthcare workers, especially in the cancer area?
Now, I think we have to be active. We have to be focused. We have to be mentally prepared. This COVID issue is not going to go away anytime soon, so you cannot expect that like the sun will rise in 3 weeks from now. You have to be prepared for the long term. I think it's the same when we confront cancer. Cancer is not a disease that we cure with one surgery. So you prepare the patient for a long fight. You have to prepare now yourself for the same. And I think that's why it's important that we keep focused. For example, at FLASCO, we are still doing our meetings, we are still doing our lectures, we're still doing our advocacy programs. We cannot stop everything. I think last year a lot of people in the world thought, oh, well, let's stop everything for a couple of months and then life will go back to normal. We'll never be back to normal. So that's why we have to get used to the new standard. And as I said, as long as we are focused, productive, and keep working hard for our patients, that's what gives us the most satisfaction that we can have and avoid burnout, stress, and all the psychological issues that have. And of course, you need to put time for yourself and for your family. That is the most important for you, because if you are not doing well, you cannot provide the patients the best of you.
Well, that was remarkable, Luis, and thank you very much for your time. It has been a pleasure talking with you here through our FLASCO page and through the help of our FLASCO personnel. Yes, any closing remark, Luis, in terms of healthcare disparities, either in cancer or in general, that you want to leave us with?
No, in the particular case, for example, lung cancer, smoking is still our problem. Our native population, for example, has a tremendous rate of smoking. I always have them in mind because we are very close to the Seminole tribe, for example, in our territory. For example, that's very interesting. They have a high rate of smoking, and still our Black population have a higher rate of cancer. So that's why I was telling you, it's not only the cultural thing, it's not only the social thing. There are biological factors, but a lot of the cancer will still be solved, for example, if we stop smoking. So very simple things to do. And the other thing is screening. In colon cancer, we still don't screen 100% of the population. In lung cancer, we only screen 4% of the population. So there is a lot of things to do, and that's why we have FLASCO here, and we're going to work together to improve these outcomes with cancer.
Well, thank you very much, Dr. Raez. It has been a pleasure, and have a very good day, folks. Thank you very much for your attention. Again, Dr. Raez, our president for FLASCO and scientific director of Memorial Cancer Institute here in Broward County in South Florida. Thank you very much for your attention.
Interview. Have a good day.